So we are just discussing again on the topic of ophthalmology, which is related to MRCP questionnaire. There are some high yield topics we have discussed last week rather. We'll relook in the topics, and whatever we have missed, we'll discuss again. Okay. So what we missed is some of the syndromes like Sturge-Weber syndrome, which usually the patient have some neurocutaneous disorders, some nevus on the face, which can be there since birth, along with some features like some amount of patient presenting with seizures and eye symptoms. So skin symptoms, seizure symptoms from the neurological side, and some amount of ophthalmological features will be in the questionnaire as a clue to diagnose as Sturge-Weber syndrome. So three main features in the imaging, they may give exactly hallmark features of CT scan, tram tract cortical calcification signs. Neurologically, their patient may present with a stroke or seizure. Along with that, the features of skin nevus like wine colored skin patches will be there, and there will be some amount of ophthalmological features will be there like eye involvement. So features will be like glaucoma, visual field defects. There may be enlarged eyeballs like ophthalmos, and maybe some choroidal hemangiomas in the ophthalmology part of the questionnaire. But along with there will be symptoms of seizures or maybe signs of port wine stain in the skin as a clue, so that you can diagnose as Sturge-Weber syndrome. The evaluation will be from the history and clinical examinations, and very pathognomonic CT features of tram tract sign may be given in the questionnaire also, and EEG also can be given in the features as a features of seizures. So all these neurocutaneous syndromes along with ophthalmological findings in the fundoscopy or visual field testing will be given in the questionnaire to diagnose as Sturge-Weber syndrome. Other than that, some multi-system disorders like neurofibromatosis type 1 also can present with some ophthalmological and other neurological symptoms, like in the leash nodule in the iris, which is defined as small benign pigmented iris hematomas, along with features of neurofibromatosis can be there. So if the question defines about the leash nodules in the ophthalmoscopy, the diagnosis will be neurofibromatosis type 1. Of course, there will be features like the age of the onset, other clinical features of neurofibromatosis like optic pathway glioma. All these clinical features may be given in the question. So leash nodules, optic pathway glioma goes in favor of neurofibromatosis, and skin nevus, seizure, and other features of ophthalmologic visual field defect, seizure, goes in favor of Sturge-Weber syndrome. So other than that, we'll discuss the most high yield topics in ophthalmology in MRCP we have discussed last time, especially come with the vascular emergencies. So if the features is suggestive of atherosclerotic disease in a patient, elderly, diabetic, hypertensive, sudden loss of vision, which is painless, and the ophthalmology feature shows pale opaque retina, that means the reduced blood supply to the part of the retina, sudden onset, painless loss of vision. Pathognomonic ophthalmological features is narrowed blood vessels, cherry red spot, and pale retina, goes in favor of central retinal artery occlusion. So it's an arterial occlusion that is a pale retina in a vasculopathy patient who is elderly, maybe diabetic, hypertensive. Most important, sudden visual loss, painless, with ophthalmological features which are very pathognomonic. So how to diagnose? Because it is a emergency, you have to differentiate it from the inflammations or infective causes, and also from the central venous occlusion, which will be a different ophthalmological features. So if it is inflammatory, you may give steroid. If it's a cardiovascular disorder, you have to stroke, you have to think about intra-arterial thrombolysis also. But ultimately, as a physician, especially in NHS scenario, you have to refer to a ophthalmologist for a ophthalmic emergency. Similarly, the central retinal venous occlusion, of course, it will be again a sudden painless loss of vision in a vasculopath. There will be no headache, photophobia, flashes or floaters, which is usually features of different vitreal disorders. And in fundoscopy, typical hallmark is stormy sunset, because there will be multiple hemorrhages, tortuous veins, cotton wool spots, and disc swelling, optic disc swelling, because there is edema. So the hallmark is stormy sunset sign for venous occlusion, and pale retina, narrowed vessels for arterial occlusion. If it is a branch retinal vein occlusion, the same stormy sunset will be one part of the retina, but if it is a central retinal vein occlusion, the hemorrhages will be all over your ophthalmoscope. Here you have to give anti-VEGF for macular edema, laser neovascularization or photocoagulation. These are the therapies, but these are ocular emergencies where main thing you have to refer to an ophthalmologist for a proper management. Other than that, the other high topic is retinitis pigmentosa, where the history may come like this. A 24-year-old young gentleman with a family history of retinitis pigmentosa is reviewed in the ophthalmology clinic. He reports worsening of vision over a few months, so gradual onset of loss of vision. And what will be your fundoscopic finding, which is most important to diagnose as retinitis pigmentosa? So if the clinical feature shows like this, bony spicules, then it is probably more pathognomonic. So night blindness and progressive tunnel vision. So periphery of the vision is getting affected. So ultimately central vision will be protected in a person who has a family history. So peripheral retinal degeneration is occurring. So what is happening when in night vision, low light pupil is dilated, then the night vision is more affected. So night blindness, progressive tunnel vision is pathognomonic of retinitis pigmentosa. So again repeating, in a young gentleman with family history, night blindness with progressive tunnel vision is a pathognomonic sign of retinitis pigmentosa. So what will be the fundoscopic findings, because they will give the fundoscopic finding for a pathognomonic feature like bony spicules shaped deposit in the peripheral retina, and mottling pattern appearances, and progressive attenuation of the retinal blood vessels, not a rapid narrow down, not a hemorrhages. So ruling out vascular pathology, which occurs more in suddenly rather than a progressive loss of vision. So night blindness and tunnel vision are pathognomonic, with bony spicules in the fundoscopic finding is featuring retinitis pigmentosa, which is a progressive loss of vision over few weeks or months. Then other thing is like posterior vitreous detachment, which usually the history will give off flashes of light, flashes and floaters. So a 71-year-old type 2 diabetes, hypertensive, having a sensation of light flashes in the right eye. Symptoms have been there for last 2 days, so relatively progressive, more in the peripheral part of the vision. So a progressive thing is going on in a vasculopath with features of light flashes. So here the diagnosis is vitreous detachment. So what happens when there is a vitreous detachment? The light falls before where it should be. So ultimately the vision is affected. So floaters and flashes will be there. So light flashes will be bright light shining. Flashes, floaters will be something floating in the vision. So these are features of vitreous detachment. And if you do a optical coherence tomography, that will confirm the vitreous detachment from the posterior part of the eye lobe. That is a confirmatory test, the OCT. The differentials are retinal detachment and vitreous hemorrhage. So if somebody says about flashes of light, it will be only vitreous detachment. If there is a dense shadow that starts peripherally and progresses towards the central vision, is retinal detachment. There is no flashes in here. In vitreous hemorrhage, there will be sudden visual loss, not a progressive one. So for a management in a physician's clinic is very simple. You just refer to ophthalmologist, but otherwise for vitreous hemorrhage, retinal detachment, these are basically ophthalmic emergencies. So patient has to be controlled in terms of the comorbidities and warned about the dangerous signs so that he can refer to ophthalmologist as quickly as possible. Another topic is glaucoma. Two types. One is the open angle glaucoma and is the angle closure glaucoma. So in open angle glaucoma specifically, there is no obstruction. So it is a problem with the flow. So the question is, what is the risk factors for primary open angle glaucoma like diabetes, family history, hypertension, Afro-Caribbean ethnicity, or hypermetropia? So if you think hypermetropia is a risk factors, so it is a risk factor for acute angle closure glaucoma, not for open angle glaucoma, where flow is disturbed but not occluded. Both the features, there will be rise in the intraocular pressure, and ultimately it will be causing problem on the optic disc, causing swelling, and the optic cup will be more in the diameter. So in open angle glaucoma, it is functionally obstructed. So hypermetropia is not a risk factor. It more occurs in myopic hypertensive diabetes with vasculopaths, and it may be higher in population with Afro-Caribbean population, but not in patients with hypermetropia, which is a risk factor for angle closure glaucoma. So what are the pathognomonic features? Peripheral visual field will be affected, tunnel vision will be the thing, and there will be of course a decreased visual acuity. So what happens? The normal cup to disc diameter increases more than 0.3. So basically increased pressure, intra-ophthalmic pressure increases, and that causes pressure on the optic disc, so it ultimately gets dilated. Other fundus findings are notching and bayoneting of the blood vessels because the optic cup is increasing in size. But mostly it can be diagnosed with the measurement of the intraocular pressure and slit lamp examinations with detailed examination of the optic nerve and fundus assessment. So ultimately for this, usually we do more medical management initially after referring to optometrist. So referring to a optometrist for ocular emergencies, measuring of the intraocular pressure, referring for fundoscopy for optic cup to disc diameter assessment is the most important findings you can find. If the intraocular pressure is as per the NICE guideline more than 24 millimeter mercury, we say that the intraocular pressure is high. Prostaglandin and analog usually comes after the timolol. So otherwise surgical intervention sometimes needed in terms of trabeculectomy. So as per the indications, the prostaglandin analog usually comes as a first line, which increases the evioscleral outflow. Beta blockers are contraindicated in asthmatic patients. Sympathomimetics like brimonidine and alpha-2 adrenergic agonists are to be avoided in patients who are taking Parkinsonian medicines or taking tricyclic antidepressants. So whenever you are having some comorbidities in your patient, you have to select your drug appropriately. In acute angle closure glaucoma, the question may come like this: a 53-year-old gentleman who presents to the emergency department on painful red eye, most important because painful red eye has other differentials like inflammatory eye disease. The increased intraocular pressure may be causing vomiting. He reports halos around lights, so there is problem with the visual acuity. which is occurring suddenly. This immediate management includes latanoprost and pilocarpine. So it means that patient having features of increased intraocular pressure, and he requires urgent ophthalmology referral. What is the mode of action of pilocarpine? So all the differential diagnosis of acute angle closure glaucoma and its management have to be in your fingertip for answering this question. Okay. So the risk factors for acute angle closure glaucoma is pupillary dilatation, because it closes the angle much more. Ultimately, drainage is obstructed of the aqueous humor, and intraocular pressure rises rapidly. So it presents with ocular pain, headache, which is not a feature of open angle closure glaucoma. There may be semi-dilated non-reactive pupil because the iris is affected. If you do a tonometry, you can find the intraocular pressure to be high, and then find a gonioscopy to measure the angle. And the first choice of drug is pilocarpine, which constricts the ciliary muscles and open up the trabecular meshwork. Otherwise, timolol is the other drug of choice. Definitive treatment is, of course, laser peripheral iridotomy. Uh, okay. And urgent referral is there for any ophthalmological emergencies. Eye changes in rheumatoid arthritis we have discussed last time also. It can present with dry eyes like keratoconjunctivitis sicca. It can present with episcleritis or scleritis. Episcleritis is basically a superficial inflammation. It's a painless erythema, but scleritis can cause, of course, a severe pain and erythema, and there is risk of perforation. So it is an ophthalmic emergency. Uh, Corneal complications also can happen, like corneal ulceration and peripheral keratitis, where, of course, the ophthalmological referral is urgent. Other than that, the medicinal effect which have been used for rheumatoid arthritis can also cause side effects like steroid-induced glaucoma, steroid-induced cataract, chloroquine-induced retinopathy, etc. So those also has to be taken into account. Other than that, the other topic is Horner syndrome, which usually, depending on the preganglionic, ganglionic, or postganglionic, the features will be different, and the question may come like, what is the cause of Horner syndrome in these cases? So, depending on the site of the lesion, the cause may be internal carotid artery aneurysm, or stroke, or syringomyelia, or maybe Pancoast tumor, or post-thyroidectomy palsy. So usually all these features, myosis, ptosis, enophthalmos, can be there in Horner syndrome, but the area of anhidrosis can be the leading feature. We can differentiate between postganglionic, ganglionic, and preganglionic Horner syndrome, which helps in differentiating the causes. So you need to know the order of neurons which gets affected from first order to second order to third order, but ultimately if there is a central lesion like a stroke, anhidrosis will affect the head, arm, and trunk. If it is a preganglionic lesion, the anhidrosis will be only limited to face, and if it is a postganglionic lesion, there will be normal sweating, no features of anhidrosis. The central causes are brainstem stroke, multiple sclerosis, syringomyelia, and cervical cord injury. And preganglionic is, which involves only the face, is Pancoast tumor and cervical rib. And postganglionic, so there will be no anhidrosis, will be carotid dissection, cavernous sinus thrombosis, and middle ear infections. So in postganglionic lesions, carotid artery, cavernous sinus thrombosis, there will be no anhidrosis. In preganglionic lesion, there will be only anhidrosis to the face, like Pancoast tumor, post-thyroidectomy. In central lesions, there will be anhidrosis to face, arm, and trunk, which happens in stroke, multiple sclerosis, tumor, etc. Okay. Other important question is relative afferent pupillary defect. So it usually tested by a swinging light test. So is the afferent pathway is affected. Usually when you shine light in right eye, the right eye must constrict, but here when the affected limb is the afferent pathway, it actually dilates. So is the afferent pathway defect. So it usually happens maybe due to retinal detachment. So whatever it is, ultimately the optic pathway to lateral geniculate body, the afferent pathway is affected due to any cause, can cause dilatation of the eyelids due to shining of the light, which usually can happen the opposite way. Uh, so otherwise, the causes affecting the optic nerve is optic neuritis, which usually inflammation of the optic nerve. A 25-year-old woman attends emergency with a gradual loss of vision, so it's a progressive process, and it is can happening over 2 days, and some curtain-like sensation is happening in her vision. So on examination, there is pain in the eye movement, which is most important sign of inflammation with a relative afferent pupillary defect. So usually the optic nerve, the afferent pathway of the vision is affected. So there is a clear sign that this patient have inflammation of the optic nerve, which is optic neuritis. So you need to know the pupillary light reflex. The afferent pathway starts with retina, optic nerve, lateral geniculate body, midbrain, and the efferent pathway from midbrain, the Edinger-Westphal nucleus to oculomotor, the third nerve, and that constricts the pupil. So if the afferent pathway is affected, that includes the optic nerve, LGB, or retina, it will be a dilatation of the pupil with shining of the light. Okay. So that been done. Optic neuritis is, we know, inflammation of the optic nerve usually can happen due to other inflammatory disorders like multiple sclerosis also, and other causes may be diabetes or chronic infections like syphilis or tuberculosis. So it will be unilateral vision loss, poor color discrimination, and there will be central scotoma, blind spot in the middle of the eye, inflammation, so pain with worse on eye movement. So treatment is high dose steroid, as we discussed last time. Also diagnosis with MRI to find the features of inflammation in the optic nerve, and usually if it responds to steroid, the visual function recovers in 4 to 6 weeks. Otherwise, if it is an infective cause of pain and decreased vision with the facial swelling associated with upper respiratory infection, we think of infection like orbital cellulitis. It is a medical emergency because admission is required for IV antibiotics. So it can happen any age depending on the vaccination status or maybe comorbidities. The infection may involve the orbital plates. So it can cause severe ocular pain, reduced visual acuity, diplopia on examination, and then we systemic features like fever, altered sensorium, drowsiness, nausea, vomiting. If the infection extends to meninges, there will be features of meningitis. So in orbital cellulitis, what happens is that the infection may go beyond the orbital plate, so there is a chances of visual loss. So admission IV antibiotics is the most emergent thing we should be addressing. Okay. If diabetic retinopathy is another high yield topic, usually it has to be differentiated between proliferative and non-proliferative diabetic retinopathy. So the proliferative retinopathy is where there is neovascularization is happening. Other than that, the non-proliferative diabetic retinopathy usually differentiated in terms of mild, moderate, and severe, depending on the area of involvement in the blood vessels of the eye. If it is a single microaneurysm, multiple aneurysms, hemorrhages, gradually the severity increases, but ultimately if there is a neovascularization, it goes in favor of proliferative diabetic retinopathy. In the different stages of non-proliferative diabetic retinopathy, usually the comorbidity control like sugar control, blood pressure control is important to limit the progression of the disease. But if it ultimately goes beyond that and causes proliferative diabetic retinopathy, the pathognomonic feature is neovascularization, then of course the laser treatment is important. Other than the comorbidities treatment, the anti-VEGF factors are there to given as an injection like bevacizumab for reducing the proliferation, but proliferative diabetic retinopathy has to be differentiated from non-proliferative diabetic retinopathy by features of microaneurysm in non-proliferative, blood hemorrhages in non-proliferative versus neovascularization in fundoscopic finding in proliferative diabetic retinopathy. So as you can see, the retinal neovascularization and fibrous tissue formation is features of PDR, that is proliferative diabetic retinopathy. Less than that is severe NPDR, where hemorrhages occurs in 4 quadrants. Moderate microaneurysm, blood hemorrhages, heart exudates in less than 4 quadrants. And if there is one or more microaneurysms, it is mild non-proliferative diabetic retinopathy. Okay, so if that retinopathy involves the macula, which is very important for vision, we call it maculopathy, but more or less the treatment remains the same. The good control of the diabetes mellitus and management of other proliferations with laser therapy. So ultimately the features are the same: the visual field reduction, decrease in the night vision, and visual acuity changes, which occurs in all types of diabetic retinopathy depending on the severity. I'll say almost this is one of the last topics of HILD, which says age-related macular degeneration, which is the most common cause of visual loss in elderly in UK population. So the question will present like that: 67-year-old woman presents for review. She has recently been diagnosed with dry age-related macular degeneration, which is the most common type, almost in 90% of the patients. And they will ask for which is the stronger risk factors for developing the condition and which can be the treatment of it. Usually there are genetic risk factors which is highest 3 times higher for patients more than 75 years versus less than 75 years. If the patient is a smoker, he has or she has 2 times more risk to develop age-related macular degeneration for visual loss. Associated comorbidities for a vasculopath like diabetes, hypertension, dyslipidemia can increase the risk of age-related macular degeneration. And of course, if there is a family history, he or she has 4 times to inherit the condition. So in fundoscopy, there will be drusen formation visible in the fundoscopy. That is a pathognomonic. So they can ask about the risk factors: family, vasculopath, age, and smoking. They will talk about giving clues about the drusen in the fundoscopic findings, and they may ask about the treatment, which is actually there is no treatment. So 90% are dry age-related macular degeneration, 10% is wet. So in dry ARMD, there will be drusen, which is the yellow round spots in Bruch's membrane. In wet, there will be exudative or neovascular macular degeneration if the macula is involved. But unfortunately, what is that in slit lamp microscopy we can find the fundus actually, but except the risk reduction anti-VEGF treatment, there is not much treatment left. Ultimately, patient will lose his or her vision gradually over the age. So I will stop there because there are multiple topics, but I have probably discussed what are the high topics and what I have missed last time. And if any questions, I can address in the remaining moments.
Yes, Sir, I have not received the last class's PPTs. That was due.
Okay, so
The
I'll send.
organizer was supposed to send.
Okay, we'll send.
Sir, one question.
Yes.
Why pain in optic neuritis?
Oh, actually, there is inflammation going on. So the pain is a sign or maybe a symptom for with eye movement. So when there is inflammation going on, it features with eye pain with movement, increasing with movement. Now, other features of sudden visual loss is like vascular and all. There is no pain, but if there is a inflammation, which is usually features uh, with pain. So that's how we differentiate between inflammatory causes versus vascular causes, because there is a inflammation of the optic nerve. That's why.
Sir, one question. Male cornea in rheumatoid arthritis. What is that?
So I didn't get your question.
Male cornea. Melt. MELT. Male cornea.
Yes. So what is happening that rheumatoid arthritis has many features, like from dry eyes to ultimately the keratitis and keratopathy. So what happens is that if there is inflammation in the cornea and causing keratolysis, thinning of the cornea, and it will be breaking down, the heart will breaking down and melts down. So ultimately, cornea involvement will cause vision, no vision, no. That's why it's called thinning of the cornea. Keratolysis is called melt cornea. It can happen due to inflammation in rheumatoid arthritis.